series this year, and we're absolutely delighted to have Professor Christina Pagel with us today. I just wanted to say a few words about the Data Science Institute here at Lancaster for those of you unfamiliar with the Institute. So our mission is to support interdisciplinary data science across the university and with our external industry and policy partners. We try and convene conversations that people might not generally have in a kind of true interdisciplinary style. So my name is Professor Karen Broadhurst. I co-direct the Institute with Nigel. Nigel, can you just come on and give us a quick wave? So Nigel is my colleague. He's a professor in our School of Computing and Communications, who was the founder of the DSI with my colleague Idris Ekley. Okay, so today's talk's been organised by my colleague Professor Professor Adam Letchford, and Adam is our foundations lead in the Institute, and he's a professor of analytics and optimization. So in a minute, I'm going to hand over to Adam to give a longer introduction to Christina, but just on behalf of the directors, huge warm welcome to you, Christina. Delighted that we have you with us. So Christina will talk for about 40 minutes, and then we'll have questions and answers. And we'll get Christina to stay with us as long as she possibly can. As I said, Christina, we've all been stalking you on Twitter and following your long threads and updates, and we're super excited that you're here today. Okay, so Adam, you're going to be introducing Christina and chairing the Q&A. And for the rest of you, if you could just keep your microphones off and your videos off until we get to the Q&A, that would be great. Thank you, Adam. Over to you.
Right, not quite sure what that noise was. Yeah, so very pleased, Christina, that you could come and speak today. And there's a sense in which you don't need an introduction because most of us will have seen you on television because you've been on, I've seen you on the news quite a lot. It's been really interesting. It's been really good for me to see somebody from operational research appear in the media and to be respected as well in the media. And that's my own area, is operational research. So I was looking at your CV, Christina, and it's quite impressive actually, but in particular because Christina is really a polymath, and there aren't too many of those around these days, I would say. Studied mathematics at Oxford, and I think have you got 4 master's degrees? There was one in mathematical physics, one in medical statistics, and then there was one in medieval history, an MA in medieval history.
And one in classics as well.
Adam, if we lost you.
Can you hear me now?
Yeah, you're back.
That's weird. I don't know what happened there. Oh, that's Teams for you, isn't it? Yeah, and then I think Christina spent some time in the US, had a fellowship with the Institute for Healthcare Improvement in Boston, and then came to the UK, back to the UK in 2017, I think it was, and became director of the Clinical Operational Research Unit, or CORU, which is at University College London, and was promoted to chair in 2018. And then probably the thing I'm most aware of here is that she became a member of Independence Age in May 2020. I'll probably let Christina explain what that means during her talk. And also Christina's received several awards and prizes and medals and so on. For example, an impact medal from the OR Society I think that was for her work on modelling of heart disease in children, and also a special recommendation from the BMJ. And she's also woman of many talents, honorary researcher at Great Ormond Street Hospital in London. So I'm actually really interested to hear what Christina's got to say. So I'll hand over to you, Christina, now. That's all right. Hopefully you'll be able to share your slides without any problems.
Yes, right. Let me. So can everyone see that? Yeah, I'm going to assume you can.
Yep.
Okay, because I can't see you now, so I'm relying on you to tell me things. So just on the operational research thing, I've had a few people say to me it's really nice to see an operational researcher on TV. And I feel like I failed you all, because to this day, I don't think anyone has any idea what operational research is. And I haven't been able to change that. And in fact, I wonder sometimes whether that's why they keep asking me back, because they've got no idea what I do, so I could plausibly be doing anything. So I wish I had taught the world more about OR than I actually have. And I'm actually not going to be talking that much about independent SAGE itself, although I'm happy to answer questions about it at the end. But more, this talk is a bit different from the talk that I gave at the AOR conference in September, if any of you were there. This is more about the kind of the biggest issues on data science in terms of COVID and where data science can help, because certainly, you know, the data science community did mobilize for the pandemic, and sometimes I wonder whether it's actually been as effective as it could have been. So kind of in this talk, I'm kind of going to go through places where I think things have gone right, and then where things have gone wrong, and where I think data science can help address that, and then just some final thoughts at the end. So things that have gone right. Well, trials for new treatments, medical trials is one of the places where it's kind of very standard science, a lot of stats, occasionally a bit of data science, but that has been really important. So, you know, one of the things that they found out was a really common steroid was found to improve survival. That happened quite early on. Trials have also been incredibly important for establishing the things that don't work, like hydroxychloroquine, but even things like antibody treatments, which were really promising, actually haven't done that well in trials. And then just today, there was another new treatment that was announced. It's a common antidepressant. It was published in The Lancet, showing that this could actually be really, really good at preventing hospitalization from COVID. So that's another really important new thing that is still happening. Modeling, I think, has been a success. I mean, the SPY-M models have had their controversies, but I think without them, you are guessing. You know, all they can do is model the scenarios that they have, and the problem is that, you know, there's a limit to what you can do in the face of uncertain policy, uncertain behaviour, and uncertain evolution of COVID. So, you know, a new variant at any point can come in and change the game, which has already happened twice. So that kind of puts just a natural limit on what it can do, but without it, you really are stuck. And I think what modelling can really do is say, this could be the extra impact of doing this versus this. I also think it's been really useful for things like thinking about schools, thinking about interventions, and I think actually one of its most successful things was in modelling the original priority groups that we use for vaccination, which is what JCVI adopted in January. And I think that those 9 groups were extremely effective. And one of the things that was quite nice about it, and actually quite ORI, was it wasn't just on risk, although risk was a big point, and that's why it's age-based, but it was also considered ease of rollout. So they actually looked at things like, do you include key workers? Do you do it by deprivation of ethnicity? And decided that would be too complicated, and adding complication would slow it down and also make it harder to communicate. And I think that was actually one of the really interesting things about how they came up with those groups. Understanding who is at risk. I think this has been really important. I mean, obviously, you know, we worked out quite early on that the age was one of the key risk factors, but things like ethnicity, key worker status, household size, so people living in more households. This is from the Imperial REACT study, deprivation, are really important things to understand. And data science has played a big part in that, not just in these kind of studies, but things like Ben Goldacre's Open Safely initiative, which allowed researchers to access GP data by bypassing the really onerous data governance, because you submit your code and they run it. I think that has been an incredibly important initiative, and has come up with some really, really important understandings. And things like the King's College Symptom Tracker app has also been really, really important in getting an idea, not just of the spread of COVID, but who's doing what and who is at risk. Vaccine and test development, obviously really important. This is just data from last week's Public Health England, or rather health security agency as they are now, vaccine efficacy data, and you can see quite how much higher hospitalization and deaths are per person for the unvaccinated versus the double vaccinated. And then things like sequencing and variant tracking. We spent the first 6 months, and there's all this kind of idea, well, COVID mutates really slowly, it's not really an issue. And then along came Alpha last December, and then Delta in May. And there have been many other variants that we've been tracking both along the world. And the kind of data science that's gone into just purely, not just sequencing, but sharing the sequencing, tracking them, assigning new variants, new subtypes to track, was all done via GitHub. It's all global. I mean, that really has been quite an enormous undertaking. So some of the things that have gone wrong. Well, logistics is one of them, and this is kind of primarily towards the beginning of the pandemic in the UK, but certainly not only. So the big one was personal protective equipment, PPE. There was a big shortage. We failed to stockpile, and it's not entirely clear that we also distributed it properly. So into care homes, there were massive PPE shortages. Now we kind of did solve that in the UK, but many other countries struggled with that as well. ICU beds and ventilators have been intermittently a big constraint. And what's quite interesting is how they set out to tackle it, because they set out to kind of had the big British ventilator challenge, but they didn't really include ICU doctors in that. And so they came up with ventilators that were not useful for COVID, and partly because of the way the kind of breathing support the COVID patients need, the kind of a bog standard ventilator isn't as useful. There were also issues with oxygen, and no one had ever considered that before, because oxygen's never been a scarce resource in a hospital. But actually, when you've got a hospital full of patients, all of whom need oxygen, and COVID patients often need insane amounts of oxygen, then they were getting stressed. And it wasn't just the oxygen supply, but the actual pipes that would pipe the oxygen around the hospital were too small to carry a big load. And so these kind of infrastructure issues were only realised quite late. And in a sense, to me, that's the kind of problem that really should have been anticipated earlier. And London is not the only place that had this. I mean, several countries, unfortunately, in the developing world, places in India, in South America, and Egypt have had oxygen disasters where the oxygen supply did fail and people died en masse in ICU. There were knock-on effects from high ICU demand from COVID patients. So COVID patients in ICU have about a 30% chance of developing kidney problems. And then they need kidney support, so renal fluids. So renal fluids were actually in very short supply during both peaks. And that meant that really affected dialysis patients who relied on those things. So you kind of have these knock-on effects. And then things like at the height of the pandemic in both March and January, and it was worse in January, when ICU units were full, you ended up having to transfer patients between ICUs, which is something you really never want to do. And that was all very complicated and actually not listening to people. It was all kind of done very ad hoc and was not particularly efficient. And the big problem, of course, here is staff. They built the Nightingale hospitals, they had the ventilator challenge, but really the problem is that an ICU bed can't treat someone, right? It's the staff that treats someone, and the scarce resource in ICU is actually nurses and not doctors. Because you need generally, one-to-one, one nurse to one patient or one nurse to two patients is the kind of ratio you're looking for. And if you effectively double your ICU capacity or more, which is what we did, which is part of, which is actually an amazing achievement, you can't just double your staff like that. And so what they needed to do is go down to 1-to-4 staffing ratios, in some places even 1-to-6. And that had big impacts, not just on the kind of care you can deliver, but the impact on ICU staff themselves and other NHS staff who worked on ICU who are not used to working on ICU. So where can data science help? Well, logistics is the bread and butter. I mean, you could do so much here. There's network analyses that, how do you model how you can spread demand over the system? How can you model where the bottlenecks are going to be? How can you optimize it? How can you think about the things that might come further down the road, things like the renal fluid problem. One of the issues with doing this is that sometimes you don't have the data. So, for instance, it became clear that staffing was a massive issue, but there's very little data on staffing. So even hospitals that have state-of-the-art electronic medical records tend not to have state-of-the-art electronic rostering. A lot of their shifts are still on paper. And so you can't actually know, how many people do you need, or what grade, or what skill to do what, and where are they, and how can they move between hospitals. That's actually quite hard to get, and is completely dealt by kind of quite different people to the people who you might go to for clinical analysis. One of the things with COVID is that you quickly realised for infection control, you had to separate out wards. So one of the things that we were working with hospitals on was, okay, how do we rearrange our ICU so we can have a clean ICU and a COVID ICU? What does that mean for how we can do elective surgery during COVID, for instance, or other kind of outpatient appointments during COVID? And the problem with that is you say, okay, well, can we get a floor plan? And they don't exist. The hospitals they just didn't have floor plans. And so you kind of have this situation where you know that you could do something, but the fundamental information that you need to do that doesn't exist. And then it's actually really hard to know, who the right people are. So the kind of people, so often when I'm doing my research or collaborating with hospitals, I'm talking to initially the senior doctors and the senior clinicians of the hospital. But if you're looking at staffing, it's the senior nurses really you need to talk to. If you're thinking about floor plans, it's a completely different department. And often I don't know who those people are, and they don't know who I am. And so they're kind of dealing with those problems and tackling those problems without knowing that there is potentially help available. And because you're not talking to each other already, and those pre-existing relationships don't exist. So I think that is kind of a real issue. And in the future, you have to almost, get that knowledge into the health system somewhere that you can use data science for these kinds of problems. Other things that have gone wrong is kind of data, and we've been hampered by lack of data about really crucial parameters. Right at the beginning, there was this uncertainty around asymptomatic versus symptomatic spread. And it matters because if your main source of spread is symptomatic, it changes the kind of policy that you want to put in, right? If you're not going to spread it until you're symptomatic, then you're focusing on finding sick people and getting them to go somewhere and not affect other people. If spread is asymptomatic, so people who are absolutely fine are going out and spreading it, then you have to start thinking about restrictions on public spaces, or masks, ventilation, contact tracing. All of that kind of things become more important. And it was kind of interesting at the beginning, they weren't sure about it, and then it became more sure that you could spread it asymptomatically. But then the early kind of clinical research was saying, well, if you're asymptomatic, you're less likely to infect someone than if you are symptomatic. And that's partly because at that point, people still thought it was mainly droplet spread. So they thought, oh, well, if you're coughing, you'll emit more droplets than someone who isn't coughing, which is true. But we didn't quite realise back then quite how important aerosol spread is, which you just get through talking or shouting or laughing. And the other thing people didn't take into account is, although on a one-to-one basis, I might be more likely to infect you if I have symptoms than if I don't, and I probably have a high viral load, for instance. The truth is that if I have symptoms, I'm also less likely to be talking to you in the first place. So I think, the kind of very traditional clinical view of looking at individual risk factors completely missed the fact that asymptomatic people are out and about in our communities having far more contacts than people who are symptomatic, particularly people who feel really ill. So actually, there was one study that estimated that actually about 50% of spread came from asymptomatic people purely because they are just out having loads more contacts. One of the other things that kind of went wrong was we did set up a contact tracing system eventually last summer. And, we tracked positive cases. We spoke to them. We got their details of their contacts. We got in touch with the contacts and asked them to isolate. But then we didn't do anything else. Now, the WHO recommends that all contacts of cases are tested routinely to pick up the asymptomatic people. But we didn't do that. And one of the things that meant is that actually we lost an amazing opportunity to understand spread a lot better. If we had routinely tested and followed up people isolating at home, whether they were a contact or a case, we could understand things like how does viral load change, how do people spread within their household, who's more vulnerable, what kind of contacts end up getting it, and so on. We didn't even link up household data. So for instance, for a long time, Test and Trace didn't know if you were living in the same house as someone else they contacted. They do now. So this was a kind of a big gap, and the Royal Statistical Society highlighted it several times last summer and said you really should be using this opportunity to learn as much as you can, and we never really have. Then there were kind of issues with lags in data, absent data, so for instance long COVID and the impact on policy. So, you know, the way COVID works is that you're infected on day 0, then you become infectious day 3 to 5, then you might get symptoms days 5 to 7, and that's kind of when you might show up in the data. And then if you need hospital, you might show up 10 to 14 days after that. Now, hospitalization doesn't depend on your willingness to get tested, so it's considered like the gold standard idea of measuring if your if your infection is spreading, but it's lagged. And so if you're going to wait, which we have done consistently, is saying we're going to wait for hospitals to be overwhelmed, then in a sense, you're waiting too long because the infections that you're responding to happened 2 weeks earlier. And death is by far the worst indicator because that's 3 weeks and onwards. So, you know, when people use death as a measure of the current pandemic, that's just a fundamental misunderstanding of what that data is telling you. And the other thing is that we haven't been measuring long COVID, and that's because it's extremely difficult to measure. You know, it represents persistent symptoms, usually longer than 12 weeks, but there's no standard definition of how long their symptoms have to last for. They are often relapsing and remitting, so you kind of get better and then you get sick again, then you get better, then you get sick again. So how do you know if it's gone away? It skews towards women in more deprived communities and adults over 35. It's a constellation of lots of different symptoms, up to 200 different symptoms have been associated with it. And it's partly because COVID can attack different organs and they have different kind of consequences. So if it attacks your gut, you might end up with really bad gut problems, or you might end up with neurological problems or so on. So because we really can't measure it very easily or routinely, it hasn't factored into either the daily dashboard or any of the SPI modelling. And so it hasn't factored into policy making. So that's the kind of thing where data can be, it's quite important to think about what you're missing out when you're measuring. There's also been a lot of confusion about the data. Like last summer, there was a massive argument all about COVID testing and what is a false positive and so on. And more recently, there's been arguments about lateral flow tests versus PCR tests. There's been a constant kind of misunderstanding about the importance of age and quite how much that skews deaths compared to cases. And so, for instance, one thing it means is that when you have a lot of spread in young people and you're only relying on hospitalizations, you don't see that happen until it moves into the older population. Alternatively, at the moment, it's causing a lot of controversy because at the moment, the most deaths are among fully vaccinated people, but that's because of the really, really strong age profile. It means that a fully vaccinated 80-year-old has about the risk of an unvaccinated 50-year-old. So there's still much more likely to die than an unvaccinated young person. So you end up with the situation where you have a lot of deaths in vaccinated people, but only because we have a lot of vaccinated old people. And that's been actually misused by a lot of anti-vax groups into saying that the vaccinations don't work, and they actually work incredibly well. Another kind of issue I think that's gone wrong with the data is that we've not been taking new variants seriously enough. So this is just a plot of the increase of Delta back in England in May. And it was going through, basically, as soon as it started growing in the beginning of April, it did double every week. It was kind of classic exponential growth versus Alpha. And it was kind of dismissed for a long time, because it wasn't creating a massive impact on cases because it was still, under 50% of cases. And there was all this kind of, well, it might be all these other things. And then you're thinking, well, if you're going to wait until you know for sure, when something's doubling every week, you literally cannot wait 4 weeks for a research study to do some antibody tests on it. Then you think, look, something's happening that's making it spread and we should react to that. But we didn't react to that. And one of the issues was quite a simple thing, was that alpha at that point, we were in lockdown. Alpha was declining. With increasing vaccination and lockdown, we had alpha beat. We didn't have delta beat. But until it actually became dominant, kind of in May, the overall case numbers were flat or declining. And that's what people were pointing to and say, it doesn't matter, it's fine. And then, of course, once Delta becomes dominant, everything shoots up, which is exactly what happened. So where data science can help with these kinds of issues is, I think, in thinking very carefully about data collection and research design, is how do you try and get this kind of data? And that's where some of the apps, things like the King's College Zoe app, has been really, really important. Now, I don't think it's a perfect app. I have some issues with it, but it still has produced so much really important insight that has even, generated hypotheses for then prospective kind of clinical trials and so on. And I actually think so. And then there's kind of so much about communication and understanding of science. And I'm not just saying that because that's kind of what I've been doing, but it is just really, really important that a lot of these issues, even if you can see it like with the new variants or you understand about the age profiles and so on, if the people making the decisions don't understand it, if the public don't understand it and that don't understand why that's the basis of policy, then it won't work. And I think there's been so much room over the last year and a half to do that kind of communication. Like the media is desperate for scientists to explain these things, right? And one of the reasons that I'm on TV a lot is because most people won't do it, right? It's not because it's not because of me, it's because they kind of run out of people who'll do it. Contact tracing, I think, is an interesting one because it is really key to pandemic control. And it's kind of what South Korea has managed to do. So South Korea hasn't had a lockdown at all and has really managed COVID very, very well. And they've done it by being absolutely rigorous about their contact tracing. And the whole thing is that if you think about what lockdown is isolating everybody as much as you can, right? You don't know who's infected or who might be infected. And so you just say to everybody, you just stay home and hopefully we'll break the chains of transmission. And what contact tracing is saying, let's target that and actually find who might have it and only ask them to isolate and everyone else goes around their lives. That's what it's for. And so you've got, say somebody's been infected and then they're in contact with all of these people over the next 5 days, and then they get symptoms. And they kind of become infectious, a day or two before you get symptoms. You're actually most infectious just before you get symptoms. So it's the people that they've kind of seen in this time period that you want to find those people and you want to tell them to stay home. And not all of them are going to have COVID, but this is better. This is better than locking down everybody. You'll just lock down these, 5, 6 people. But once you have symptoms, you actually then have to get a test, right? So you have to make it as easy and quick as possible for people, once they have symptoms, to get tested. Now, in the UK, currently, it says you can get a PCR test if you have any of these 3 symptoms: a high temperature, a new continuous cough, or you've lost your sense of smell or taste, or it's changed. We are one of the very few countries that is using this list of symptoms because it is out of date, and it's been out of date for a very long time. Most countries have a list of up to 10, 15 different symptoms. But the Zoe symptom tracker app, and this is one of the things it's really, really good at, says, actually the top 5 symptoms now in vaccinated people and in children are runny nose, headache, sneezing, sore throat, and loss of smell. Those are the symptoms. For children, they also often present with diarrhea or vomiting or stomach pain. But if you don't know that, if you think I'm sneezing, it can't be COVID, you won't get a test. So you're missing out the first thing about finding the infected people. And then at the moment, there's a legal obligation on you to isolate if you test positive, and you risk a £10,000 fine if you don't. But if you cannot afford to stay at home. You know, if you do not get sick pay, if you're in the gig economy, if you have care responsibilities, all kinds of things, then you have no incentive to go out and get a positive test because you lack the ability to do anything on it, to act on it. And so they showed this in the mass testing pilot they did in Liverpool at the end of last year, where only 4% of the city's poorest people volunteered to take part. And we also know that even though there is some self-isolation pay for people who were below a certain salary, it was only £500 for 2 weeks. It's not even minimum wage. And actually, you know, 60% of those requests were refused anyway. And it's interesting because the government's behavioural subgroup has consistently raised from the very beginning that they need to support people to isolate. And most Western European countries do pay full sick pay for isolation as a contact. And we don't. And it's been a consistent problem that a lot of people then don't isolate because they can't. Let's assume that you have someone, they get symptoms, they're willing to get tested and they can get a test within a day. Now, then it takes another day for them to get a result. And then once they've got a result, then they have to get contacted by NHS Test and Trace. They then have to, their contacts then have to be contacted and told to stay home. And until that happens, all of these people who were contacted the infectious person are out in the community. So speed is of the essence here. And in South Korea, they've got this down to maybe 48 hours. And here, we've never really got that slick. It's still it takes quite a long time. So I think, you know, one of the issues that we've had with it is that we put too much reliance on the app. I don't know if you remember back in April, Matt Hancock was all about, oh, we're going to have a world-beating app. And there was no real mention of the kind of personalised, you have to talk to people or support them to isolate. None of that was really mentioned. It was very technological. There was a disregard for public health expertise because public health experts at the time were shouting, this isn't the way to do this. We should be learning from East Asia where they're doing this really well. But one of the things that the House of Commons Committee said the other week was actually the UK was incredibly bad at learning from other countries. And I think this is one of the things where we really didn't learn. The little or no support for isolation I've already mentioned, and not enough data being used or collected I've also spoken about as well. Another issue, which is kind of almost the first step of contact tracing, is testing. So when you have poor testing, that undermines the whole system. So the most recent thing here is the immense lab scandal in Wolverhampton, where they had about 400,000 tests they processed over a month. And almost all of those they sent back were negative, including negative results of about 43,000 people who were actually positive. And a lot of those people would have been children, and that meant they went back to school, they went back to work, they carried on mixing. And it's created a real explosion of cases in the southwest, which was most affected. So this is a plot of cases per 100,000 people per week. This is for 5 to 9-year-olds. And the 13 most affected local authorities by this lab scandal is in red, and the rest of England is in black. And this is the period of infection. You can see here these artificially low case numbers when they were being sent back false negatives. Then a kind of bump, then another big dip. And then once it kind of cleared up, and this was actually before the story broke. So it wasn't people seeking to get tested. This was before the story broke, which was 15th of October. Cases started coming back and they've absolutely shot up. And it's not just in this age group. Every single age group in these local authorities has exactly this pattern. There's also been issues with poor data storage and transfer design. I don't know if you remember last September, there was September 2020, there was a big hoo-ha because the dashboard had lost 16,000 cases. And this turned out to be an Excel issue. And it turns out that each lab would send its test results to Public Health England as a CSV file, you know, fine. And then PHE would collate those CSV files together. And what they would do is they would put them all, basically append them all into an Excel file that the dashboard team would then just read off and stick on the dashboard. But they used XLS file instead of an XLSX file. And that meant that when they went over 64,000 rows, it just cut off the rest of the data. And that's literally what happened. And, you know, I mean, I love Excel. I mean, I use Excel a lot, but it's not like you wouldn't use it for this. I still find it astonishing that no one thought, why would you use Excel for such a really important job of collating this data and using it for a dashboard? So where can data science help? In terms of the NHS app, it can help with app design, rollout and use, and I know that a lot of data scientists actually were involved in that. It can help in data collection and research design, and I know that may not be the most exciting thing in the world, but it's absolutely crucial, because when it goes wrong, it matters. Automated anomaly detection. You know, I would have assumed that even if the lab wasn't doing quality control checks, which it totally should have been, the Public Health England would know exactly what labs were sending back what tests, and they would have some kind of automated process that would check for anomalous readings. So, for instance, the national positivity rate was about 8% during this period. And then for 1 week, some tests in Sheffield went to the lab, and they came back from that lab with a 0.2% positivity rate. That should have been an immediate red flag. That's anomaly detection. So I feel like if we could just put that in place, you could have saved thousands of lives, not thousands, hundreds of lives. But at the same time, unless people get tested, unless they know that they have COVID or might have COVID, unless they get tested, are willing to provide contacts and then can actually isolate, it's all a bit pointless, right? And that bit is not a data science problem. That is a public health and communication problem. Other things that have gone wrong are vulnerable populations. So care homes is obviously one of the big ones. And you can see, so this is deaths over the pandemic. The orange line is deaths in hospital, but the red line, which is the next two peaks, are deaths in care homes. And there have been literally thousands of deaths in care homes. And they didn't need to happen. And what you have is you have an interaction between the most vulnerable people in our society, both through age and other health conditions, and you have a vulnerable population who are caring for them. So what it is that care home workers tend to be very poorly paid. Many of them do not have sick pay. They do not qualify for sick pay. And so they literally cannot afford to isolate. Because they're badly paid, they normally do agency work, which means they don't just work in one care home, they work in several care homes. So if you have someone who's infected, they will go and they will work in several care homes and potentially spread it. They also often, because of poverty, live in overcrowded housing, actually often with each other, and so it can spread among the working population as well. And actually, you know, if you look at the House of Commons report, they were saying that one of the issues is that the SAGE modelers didn't know this context, and so they completely missed the danger of care homes, because this kind of really important knowledge was not in the room. Key workers were vulnerable, particularly during lockdowns, and that's not just education and health, it's people working in supermarkets, in factories, taxi drivers, security guards, bus drivers, and so on. And actually, key workers are more likely than average to be of an ethnic minority, women, or born outside the UK. Ethnic minorities and deprived communities have been at a lot more risk throughout their high risk of exposure and high risk of getting sick and dying if they are exposed. And so this is the monthly mortality rate for COVID deaths by ethnicity. This line here at the bottom is white ethnicity. So you can see that pretty much throughout, white people have been at by far the lowest risk of death. And if we look at it by deprivation, this line at the top, these two lines at the top, are the most deprived deciles. And this line at the bottom is the least deprived decile. So you can see again how deprivation and ethnicity, like it hasn't been a pandemic that has affected everyone equally. So how can data science help with this? Well, it can't, right? This is not a data science issue. The best that we can do is measure it. And the other thing we can do is to insist that public health experts and social scientists are in the room. The people who understand demographics, epidemiology, inequalities, the ways people's lives can affect their health and the spread of disease, they have to be there, right? And I think sometimes in the UK, there's been this idea, there's a magic bullet that science and technology can give us, and there's some things that technology cannot solve, and they cannot solve inequality. And I think that's part of why we have to not just be humble about our own expertise, but advocate for the expertise of others. So last slide. Just to kind of summarize, I think, more varieties of expertise help reduce the unknown unknowns. And they reduce the risk of saying, if only we'd known that problem. And that's, for instance, like the care home deaths, that was avoidable. Thousands of people who died who didn't need to die. And I think, this also has to be an emphasis on public health. I think at the beginning in the UK, we were very focused on ICU and thinking about technologies. How can we make ICU better and more efficient and save people? Whereas, by the time you're looking at ICU, you're looking at a massive burden of ill health in the community, right? Prevention is better than reaction for an infectious disease. The boring prep work is extremely crucial. You need to have the right data. It has to be collected. It has to be collected in the right way. It has to be reliable, and it has to be right. It has to be consistent, reproducible, usable, and it has to be transparent. All of those things. And there has to be a really clear understanding of the limitations of real-time data. So real-time data has been so important, particularly when we were going through much quicker exponential growth phases, when it was doubling every 4 days, every 7 days. You need to kind of know what's going on now, but you also need to know the limitations of what that data is telling you. I think communication is crucial, and you shouldn't spin, you shouldn't help others to spin. I see it most often in deaths. So the way that, I'll give you an example for death. So the way that deaths work is that it takes a few days to get registered as a death. And if you die at a weekend, it takes a few days. And so every single week as clockwork, the highest number of deaths reported is on a Tuesday, and the lowest number is on a Sunday or a Monday. And on a Sunday or a Monday, certain parts of the press will pretty much every week run a story saying, look how low deaths are. And every Tuesday, and Wednesday, other bits of the press will run a story saying, look how high deaths are. Whereas in fact, if you look at it by date of death, it's not nearly like that. And it's this kind of spinning of results that to emphasize a certain point, I think is just completely wrong and unhelpful. And I think, think about, can you be most helpful, not by coming up with your own epi model, right? We have some of the world's best epidemiologists who've been doing it for years. Like, how much are you going to be able to do on your own computer without access to the fundamental data that you need to parameterize it? So can you be most helpful by emphasizing the basics of how the mathematics of infectious disease works to policymakers and the public? Things like exponential growth, things like the nature of uncertainty and evidence, what modeling means, what the data means. And I think, ask yourself whether your favorite type of data science is actually helpful before you kind of, weigh in. And I think I'll just end by saying, that we've just lived through this pandemic. I think everybody has learned an enormous amount. So I think, let's plan for the next one, because it is coming. And that's it.